Okay, good afternoon all. We can see the genital injuries. It is the injuries and trauma to the pelvic floor. In that, the main injuries, that is, you can see the outline, that is the definitions, classification, anatomy and physiology, causes, signs and symptoms, risk factors, diagnostic procedures, complications, treatment, prevention, risk of reoccurrence, nursing management, references. Then first coming to the female genitalia, external female genitalia, vulva, clitoris, major and minor labia, vagina. And internal female genitalia includes uterus, ovary. Then injuries to the birth canal. Not so uncommon, spontaneous or assisted deliveries. That is, spontaneous means due to any external applications like that, in any other external things. We may accidentally we get the injury, that is the spontaneous. Assisted deliveries, that is due to the perineal tear or episiotomy. Not giving timely episiotomy. Episiotomy means we are cutting the vaginal opening to widen the opening of to, that is to easily delivery of the baby. That is giving a path, that we are giving a wound, creating a wound, that is called as episiotomy. So in not giving timely episiotomy, there will be a perineal tear may occur. And also if we are assisting with any applications, that is the forceps, vacuum, likewise any applications we are assisting, in that time also sometimes some cases there will be injury may occur. And depend upon the care provided by the obstetrician during the time of during the labor time, delivery time, we are giving the care. Then avoidance, early detection and prompt management, that is the key to reduce the significant morbidity. Okay. Then classification, that is the classified injuries to bony parts, injuries to symphysis pubis, injury to sacrococcygeal joint, injury to sacroiliac joint. Then injuries to soft tissue, that is injury to vulva, perineal tears, laceration of vulva and vagina and cervix, rupture of uterus. Uterine rupture, last class I had, that is uterine prolapse, that is okay. Then the vagina, it is the fibromuscular membranous sheath, communicates uterine cavity with the exterior at the vulva. It extends from the vestibule upwards and backwards up to the vaginal part of the cervix. Walls, anterior 7 cm, posterior 9 cm and 2 lateral walls 44. Then the lower third resembles the figure of H. Middle third is like transverse slit and upper third is rounded in shape. Then structures, mucous coat lined by stratified squamous epithelial without any glands. Submucous layer consists of loose areolas tissue. Muscular layer consists of inner circular and outer longitudinal fibrous coat from endopelvic fascia. Then cervix. The cervix means the cervix is constructed part of the uterus, separated from the body by the construction part known as the isthmus and behind by the transverse ridge considered as torus uterus. This contains a cervical canal which communicates the uterine cavity with the vagina. It extends downwards and backwards from the isthmus, protrudes through the anterior wall of vagina, which divides the cervix into supravaginal and vaginal parts. Then structure of cervix, serous cord from the peritoneum, which covers the posterior surface of the supravaginal part. Muscular cord, disposed smooth muscle, some parts produced from the collagenous and elastic fibrous tissue. Mucous membrane by columnar epithelium and stratified squamous epithelium. Then ligaments of cervix, laterally by pair of McEnroth's ligaments, posteriorly by pair of uterosacral ligaments. These ligaments have striped muscles and layers of blood vessels and lymphatics. On each side, the lymphatic drainage into external iliac, obturator lymph nodes, internal iliac grooves and sacral grooves. Then coming to the perineal tear. Perineal tear, that is the anatomy, pelvic floor, how the pelvic floor will be there, you can see, and you may already studied about the anatomy and physiology of this gynecology, that is the reproductive system. So here only I have given the pictures where that is the perineal tear will occurs. You may read and understood these all slides. Okay. Urogenital diaphragm is there. These all are the figures. How the then perineum, how it is in diamond shape, how it is looks. Then perineal body, how in the extension muscles, that is the vagina. Then you can see. Then perineal tear, that is the gross injury due to the mismanaged second stage of labor. That is, mismanaged means not giving timely proper giving time of episiotomy. That is the gross injury, that is mismanagement of the second stage of labor. More common in primigravida than multigravida. Due to extension of episiotomy, posteriorly it involves the anal sphincter from back and obliquely upwards into the lateral vaginal wall. Etiology: overstretching of the perineum, rapid stretching of the perineum, inelastic perineum. Causes and predisposing factors: obstetric emergencies, malpresentation such as breech, contracted pelvic outlet, spontaneous labor, operative vaginal deliveries, macroscopic babies. That is, I have already first in the introduction part I had told how this injuries that is occurs there. That is obstetric injuries you may see due to breech. That is, the normal position of the baby is cephalic or vertex position. If it is in breech, sometimes it will be the widened opening will be needed. So that is the injury may occur. Then contracted pelvic outlet, that is the pelvic outlet. The baby this doesn't have sufficient space to go out of to the outside the towards the wall. So in this case we can say that is contracted pelvic outlet. Then spontaneous labor, not the timely labor occurs. Operative vaginal deliveries, that is due to the forceps and vacuum. Then macroscopic babies, that correct, big size babies that we can macroscopic is we can be seen in diabetes, gestational diabetes mothers, big babies. Non-obstetric injuries, I had told now, non-obstetric injuries are due to some other accidental happens, that is the rape, molestation, fall, accidental injuries like road traffic accident, bullhorn injuries. Okay. Then degrees of perineal tear. The first degree limited to vaginal mucosa and skin of the introitus. Second degree extends to the fascia and muscles of the perineal body. Third degree trauma involves the anal sphincter. Fourth degree extends to the rectal lumen through the rectal mucosa. These degrees you can assess by seeing this. Before I have shown the sides, that pictures, you have gone through that pictures, then only you can identify these degrees of perineal tear. Okay, a rare type of tear is central tear of the perineum when the head penetrates. That's the penis head penetrates first through the posterior vaginal wall and through the perineal body and appears through the skin of the perineum. It usually occurs in the patients with a contracted outlet. That is the small babies, children, that is due to the rape conditions. That is mainly the center tear like may occurs. Then third degree perineal tear, fourth degree, you can see. Then first degree tears, spontaneous tears originate near the midline of the perineum, but when they are traced upwards and they are invariably found to extend into one or other posterior lateral vaginal sulcus. Sometimes the upper limit of the tear is felt better, helpful to catch the upper edge of the vaginal tear. If a double tear is found, care must be taken to unite the lateral vaginal walls to lose the posterior tongue. Tears of the anterior vaginal wall often involve the tissues close to the urethral meatus. Later, patient is unable to void urine because of the muscle spasm, consequent on the bruising around the urethra and bladder neck. Then third degree tears. A tear has extended into the anal sphincter of the canal. Any fecal contamination is cleared away and area drenched with aqueous solution of antiseptic. The muscle wall of the rectum and anal canal is closed by interrupted or continuous arcade. Sutures. Please so that the suture avoids the bowel mucosa. Disadvantage, appearance of small rectovaginal fistula at the upper end of the wound. Then symptomatology, immediate bleeding, traumatic PPH, hemorrhagic shock, perineal pain, perineal hematoma, urinary retention due to painful perineum, urinary incontinence, and anorectal dysfunctions like fecal incontinence. You can see with the symptoms, by these symptoms, that is the severe PPH, that is any perineal tear occurs, there will be a severe PPH will be there. Then pain will be there. There will be hematoma. Due to this bleeding, the blood may be clot inside the vagina. Because of this, after the episiotomy, we are suturing the walls. So, without knowing that the perineal tears occurs, we have sutured the walls and the blood may be clot inside the vagina. That is called as the perineal hematoma. Then urinary retention, that is the urinary, lack of we are not giving proper care or not assessing the proper position. You can say that the urine will be that is the bladder sphincter, that is the urethral meatus, these all we will be sutured and the urine is not able to comes out. Then urinary incontinence. Then anorectal dysfunctions like fecal incontinence. Delayed infected perineum, perineal abscess, uterovaginal prolapse, urinary incontinence, fecal incontinence, dyspareunia, feeling of slack vagina during coitus, bleeding, blood disruption of anatomical continuity. These all things you may not. Feeling of slack vagina during coitus means that the vagina will be floating like this. Okay. Then prevention, liberal use of episiotomy, proper conduct of labor during second stage, perineal support during second stage. Repair of perineal tear, first degree, sometimes doesn't require suturing or can use 1 or 2 interrupted suture. Second degree, vaginal mucosa is to be sutured first. The first suture is placed at or just above the apex of the tear. Thereafter, the vaginal walls are opposed by interrupted sutures with the chorionic, chronic catgut number or from above downwards till the foreshet is reached. The suture should include deeper tissues to obliterate the dead space. A continuous suturing may cause shortening of posterior vaginal wall. Complete perineal tear occurs. The rectal and anal mucosa is sutured from above downwards by interrupted sutures. Muscle walls including the pararectal fascia are then sutured by interrupted sutures. The torn ends of the suture extraneous and sutured with the figure of 8 stitched by another interrupted suture. Perineal skin by interrupted suture. After care, low residue diet, stool softener, SIDS bath, BD. Oral SIDS spelling mistake is there. You note SITS. Then oral antibiotics, anaerobics, analgesics. Complications if left untreated: infection, hemorrhagic shock, cosmetic disadvantage, 3rd and 4th degrees tears if left untreated may lead to fecal incontinence. Prevention of perineal tear. Well supported of the perineum at the time of delivery of the head. Delivery of early extension is to be avoided. Spontaneously forcibly delivery is to be avoided. To deliver the head in between contraction. To perform timely episiotomy. To take care during delivery of shoulder. Periurethral tears. Vaginal tears can also occur at the region around the urethra. The opening through which urine comes out, these are then called a periurethral tears. Okay. The problem with these type of tears is that there may be profuse bleeding from even a small tear since the region has a large blood supply. Causes. The commonest cause of periurethral tear is a sudden extension of the fetal head at the time of delivery. Normally, the fetal head is in a position of flexion with the chin touching the chest at the time of delivery. After crowning occurs, the head is borne by extension. The gradual extension will not put much pressure on the anterior or upper part of the vagina, but a sudden extension will cause a sudden pressure on upper vaginal area, resulting in periurethral tear. How we can prevent? It is important for the doctor or midwife to press gently the fetal head at the time of delivery and guide it a slow and gradual extension at the time of birth. This point you should not, you should be doing during the time of labor. That is, when you are we are giving the labor room posting, we are telling you the children to, students to give perineal support. That is the point how we can prevent. Okay, clearly you should read, and this should be practiced during the time of your labor room posting. Okay. Treatment. Periurethral tears needs to be stitched carefully under proper light. If not repaired well, or if it is not diagnosed after the delivery, it can bleed continuously for quite time sometime and cause many other problems. It is advisable for the woman to use cold packs on the site of tear at least 7 to 10 days. Instant healing. Use anti-inflammatory painkillers like ibuprofen. Then during the course of pregnancy, the body is primed to heal quickly. The immune system is more efficient. Usually, therefore, the bone heal few weeks after childbirth. Complications if not treated: continuous bleeding, infections in the tears, severe pain and inflammation, urine retention due to inability of the woman to pass urine through the inflamed urethra. Vaginal lacerations. It involves the middle or upper third of the vagina but not associated with the lacerations of the perineum or cervix. Common during divorces, delivery or vacuum. Sometimes even with the spontaneous delivery. Frequently extended deep into the underlying tissues and give rise to hemorrhage. By appropriate suturing, the tears are repaired by interrupted or continuous chronic catgut. Treatment: minor, no suturing; major, repair using absorbable suture. Cervical tear lacerated over half of the vaginal deliveries. Most of these are less than 0.5 centimeter. Deep cervical tears may be extended to the upper third of the vagina. In rare instances, the cervix may be entirely or partially avulsed from the vagina with the cloacasis into the anterior, posterior or lateral fornix. Rarely, cervical tears may extend to involve the lower uterine segment, uterine artery, its major branches, even though the peritoneum. Cervical lacerations up to 2 cm must be regarded as inevitable in childbirth. Such tears heal rapidly. In healing, they cause a significant change in round shape of the external os before cervical effacement or dilatation to the appreciable lateral elongation after delivery. Causes: rapid delivery of fetus, assisted deliveries, rigid cervix. Diagnosis: deep cervical tears should be always suspected in cause of profuse hemorrhage during after third stage of labor. It is firmly contracted. Extent of the injury can be fully appreciated only after adequate exposure of visual inspection of the cervix. Treatment: deep cervical tears require surgical repair and the lacerations limited to the cervix or extends into the vaginal fornix. Results are obtained by suturing the cervix, either interrupted, running, absorbable sutures and suitable. Complication: infection, persistent cervicitis, extensive scarring, sterility, repeated abortion, premature labor. Then healing of wound healing. Primary intention occurs in clean incised wounds such as surgical incision. It produces clean, neat, thin scar. Healing by secondary intention refers to a wound which is infected, discharging pus, or wound with a skin loss. Factors influencing wound healing: general age and nutrition, that is the protein deficiency, vitamin C and vitamin A deficiency, hormones, triglyceride, medical disorders, anemia, jaundice, diabetes, blood dyskaryosis. Local position of the wound, faulty technique of wound closure, poor blood supply, impairment of lymphatic drainage, tension, movement, exposure to ionizing radiation, foreign bodies, tissues, reaction and inflammation and necrosis. Okay, thank you.